Okay, let's unpack this. When someone gets a breast cancer diagnosis, it's just an avalanche of information, isn't it?
Absolutely, it's overwhelming.
And we've got these sources here that really zero in on two critical pieces, staging and biomarkers. These aren't just abstract terms, they literally shape the patient's entire treatment journey.
Precisely. This deep dive is really about understanding the blueprint clinicians use. Think of it like this. You need to know two fundamental things. First, where is the cancer? How far is it spread? That's staging.
Got it. Location and extent.
Right. And second, what is the cancer actually doing on a molecular level? That's where biomarkers come in.
Okay.
These two together, staging and biomarkers, they're the pillars for figuring out the prognosis and, crucially, picking the right personalized treatment.
And this matters so much for you, the listener, because oncology today is so much more than just, measuring a lump.
Exactly. It's incredibly individualized now.
So our mission today is to break down the TNM system, that's the staging part, and then get into these really important molecular markers that tell us about the tumor's biology and how to target it. So we're talking about the AJCC system, right? American Joint Committee on Cancer, now in its 8th edition.
That's the one. It's basically the universal language for cancer staging worldwide. Let's start with the T. That stands for the primary tumor.
Okay, T for tumor. Size and extent.
Yep. The T classification gives us that core physical measurement right where the cancer started. And the key thing here is the precision the AJCC demands. It's not just small or large. No, they measure it down to the nearest millimeter. And it doesn't matter if that measurement comes from imaging before surgery, that's clinical T or CT,
right,
or from the actual removed tumor after surgery, pathological T or PT. The classification rules are the same.
But the path report, PT, that's usually the definitive one.
Generally, yes. It takes precedence because you're looking directly at the tissue. It's the most accurate measure.
And the sources really stress this precision, especially for smaller tumors. T1 isn't just T1. It's broken down even further. Why is that tiny difference, say, between 1 millimeter and 10 millimeters so important?
Well, that's where the prognostic information really lies. T1 means the tumor is 20 millimeters or less. But even within that, there are distinct categories.
What T1mi?
Exactly. T1mi is microinvasive 1 millimeter or less. That generally behaves much less aggressively than, say, a T1C tumor.
And T1C is?
T1C is over 10 millimeters, but still 20 millimeters or less. So you have T1 millimeter, T1A, 1 millimeter to 5 millimeter, T1B, 5 millimeter to 10 millimeter, and T1C, 10 millimeters to 20 millimeter.
Wow. Okay, so that level of detail within the small category really impacts the outlook?
It absolutely can. It reflects a different biology, a different risk profile. Even at those small sizes, it feeds into the overall stage grouping later.
And then just for context, T2 is bigger.
Right. T2 is anything over 20 millimeter up to 50 millimeter. And T3 is anything over 50 millimeters. So you see the steps.
But then T4 throws size out the window, doesn't it? It's about invasion.
Exactly. T4 means it's advanced locally. A T4 tumor, regardless of its measured size, has grown directly into the chest wall, the ribs, the deep structures, or into the skin.
Causing things like ulcers or obvious skin nodules?
Yes, ulceration or those macroscopic nodules. And here's a really crucial point the source makes. Simply invading the pectoralis muscle, the big chest muscle on top of the ribs, that doesn't automatically make it T4. It has to be deeper into the actual chest wall structures. That's T4A.
Okay. So muscle invasion alone isn't T4. That's a critical distinction for surgery planning, I imagine.
Huge difference. It changes the stage, the prognosis, and definitely the surgical approach.
So that specificity is amazing. Before we hit the lymph nodes, what about those in situ things like DCIS and LCIS?
Good question. Ductal carcinoma in situ, DCIS, is still staged. It's classified as TIS in situ. It means that cancer cells are confined within the milk ducts. They haven't broken out.
Okay, TIS for DCIS, but LCIS is different now.
Yes, and this is a really important update reflected in the 8th edition. Lobular carcinoma in situ, LCIS, was actually removed from TNM staging altogether.
Removed completely. Why?
Because our understanding evolved. LCIS isn't really seen anymore as a direct anatomical step towards invasive cancer in that specific spot.
So it's not stage 0 like DCIS?
No. It's now considered more of a marker, a sign of significantly increased risk for developing invasive breast cancer, potentially in either breast down the line.
So it signals risk, not pre-cancer at that location.
Exactly. It requires close watching, maybe risk-reducing therapy, but it doesn't get a T, N, or M stage itself. It shows how the system adapts as we learn more about the biology, not just the anatomy.
Okay, so T gives us the primary tumor details. Now, N, regional lymph nodes. This is often the first sign the cancer might be trying to spread, right?
Historically, yes. The status of those regional lymph nodes under the arm, axillary,
Yeah.
above the collarbone, supraclavicular, near the breastbone, internal mammary, has been the single most important predictor of whether the cancer will come back.
Disease-free survival, the sources call it.
Exactly. But here's the catch. Just feeling under the arm during a physical exam to check for involved nodes, it's notoriously unreliable.
How unreliable.
The accuracy is cited at only around 33%, really poor,
Wow.
which is why modern staging relies heavily on imaging and biopsies before surgery. Ultrasound-guided FNA fine needle aspiration or a core biopsy of suspicious nodes is crucial for getting an accurate baseline end stage.
Okay, so we need that tissue confirmation. Now, this is where it gets really granular, especially with micrometastases. Can you simplify that end staging spectrum for us? What are the key cutoffs?
Let's break it down by size. At the very, very smallest level, you have what are called isolated tumor cells, or ITCs. The code is PN0I+.
PN0I+, meaning?
It means pathologists found malignant cells, but they're either single cells or tiny clusters no bigger than 0.2 millimeters, just trace amounts, really.
Okay, super tiny. What's the next step up?
That's PN1AA. The MICE stands for micrometastases. Here, the cancer cell clusters are definitely present and measurable, larger than 0.2 millimeters, but none of the clusters are bigger than 2.0 millimeter.
So 0.2 millimeters to 2.0 millimeters is the micrometastasis window.
Precisely. That 2.0 millimeter mark is the key dividing line.
Why is 2.0 millimeters so important?
Because once you have even one deposit of cancer in a lymph node that's larger than 2.0 millimeters, you've crossed into macrometastasis territory. That's typically PN1A, assuming it's in 1 to 3 axillary nodes.
Okay, so ITC trace, micro, 0.22 millimeters, macro 2 millimeter. That helps visualize the burden.
Exactly. It reflects the increasing amount of cancer that has escaped the primary tumor site.
Now, there was that ECOSAW 0002 trial mentioned. It looked at using special stains immunohistochemistry, or IHC, to find these really tiny hidden deposits, the ITCs, in sentinel nodes. If we can find them, shouldn't we always look?
Ah, that's a really interesting point and highlights attention in practice. IHC is super sensitive. Yes, it can pick up those ITCs. But the Z0010 trial basically showed that routinely hunting for and finding these tiny ITC deposits using IHC didn't significantly change patient outcomes, overall survival, or recurrence rates when patients received standard therapies anyway.
So finding them didn't lead to doing something different that actually helped more.
Largely no. The conclusion was that routine IHC just to find ITCs isn't generally warranted. It adds information. Sure, it has some prognostic association.
Meaning it tells you something about risk.
Right, but it didn't reach the threshold of therapeutic relevance. It didn't reliably change treatment in a way that improved survival enough to justify routine use for everyone. It could lead to anxiety or potential overtreatment without clear benefit.
That's a crucial distinction, prognostic versus therapeutically relevant. Okay.
Wow.
And beyond the size of metastasis in the nodes, the location of the involved nodes also matters, right? The level 1, 2, 3 thing.
Absolutely. The axillary lymph nodes are grouped into 3 levels based on their position relative to the pectoralis minor muscle. Level I is lowest, level 3 is highest, up near the collarbone.
And cancer tends to spread sequentially.
Typically, yes.
Yeah.
Level I first, then level 2, then level 3. The N category reflects this progression. N1 usually means movable, level I or 2 nodes are involved. N2 implies the nodes are fixed or matted together, or that only the internal mammary nodes are involved.
And N3 is the most advanced regional spread.
Correct. N3 indicates involvement of the level 3 infraclavicular nodes, or the supraclavicular nodes above the collarbone, or a combination of internal mammary and axillary nodes. The anatomical extent dictates things like radiation fields. It's all interconnected.
All right, that brings us to the last letter, M, for distant metastasis. Simplest definition, biggest impact.
Couldn't say it better. M1 means the cancer is spread beyond the regional lymph nodes to distant organs or tissues. That's stage 4 disease. M0 means no evidence of that spread.
But wait, there's that little I plus again, CM0, I plus.
Ah, yes, the return of the isolated cells. CM0 plus means clinically, using scans and exams, there's no sign of distant metastases, so M0. But using highly sensitive microscopic or molecular tests, tiny numbers of tumor cells, still defined as AL.2 millimeter, have been detected in places like the bloodstream, bone marrow, or maybe distant lymph nodes, not typically drained by the breast.
So not visible on scans, but detectable molecularly. What does that mean for the patient? Is it stage 4?
Technically, no, it's not classified as M1 or stage 4, but finding those cells, CM0I+, definitely carries a more guarded prognosis. It suggests a higher risk that overt clinical metastases might develop later on. It's a sign that cancer has the potential for distant spread, even if it's not established yet.
That makes sense. And the survival stats really underscore the gravity of M1 disease.
They do. Distant metastases are, unfortunately, the most common cause of breast cancer-related death, often occurring even years after the initial treatment, sometimes up to 10 years or more.
Where does it typically spread?
The most frequent sites, in order, are usually bone, then lung, the pleura, lining of the lung, soft tissues, and the liver. Brain metastases are a bit less common overall.
But more likely in certain subtypes.
Exactly. They are disproportionately more common in patients with triple-negative or HER2 positive breast cancers. Biology matters, even in where it spreads.
Okay, so we have T, N, and M. The system then combines these into an overall stage group, stage 0, I, 2, 3, free. Can you give an example of how T and N interact in the early stages?
Sure. A key rule, as we said, is any M1 disease is automatically stage 4. But look at stage IB. That group includes patients with a very small primary tumor, HEO or T1, but who have those nodal micrometastases we discussed, PN1MI.
Ah, so even tiny node involvement bumps it up from the earliest stage.
Right. Stage IA would typically be T1, N0, M0 solid tumor, no nodes, no distant spread. Finding even those micrometastases in 1OI signifies some lymphatic escape, so it gets grouped slightly higher into stage IB, reflecting that small increase in risk. It shows how the system weighs both primary tumor size and the extent of nodal spread right from the beginning.
Okay, that TNM system gives us a really detailed anatomical map. But now section 2, this is where we shift gears, right? From where the cancer is to what it is biologically speaking.
Exactly. This is the other essential half of the equation. Staging tells us the extent, but biomarkers tell us about the tumor's personality, its drivers, and crucially, its potential weaknesses.
How we can fight it, essentially.
Precisely. We need to know the molecular signals that tell us if it will respond to specific targeted therapies.
Let's start with the ones most people have probably heard of. The hormone receptors, ER and PR, estrogen receptor, and progesterone receptor.
These are fundamental. They are proteins found inside many breast cancer cells, and they're very common, detected in over 90% of the well-differentiated, slower-growing types, like invasive ductal and lobular cancers.
And their presence means the cancer uses hormones to grow.
Essentially, yes.
Yeah.
If ER and PR are positive, it means the cancer cells have receptors that bind to the body's natural estrogen and progesterone, and these hormones act like fuel, stimulating the cancer to grow and divide.
So counterintuitively, having these receptors is actually good news, in a way.
In a very important way, yes, because it means the cancer has an Achilles heel. Their presence is highly predictive of a good response to anti-estrogen therapies.
Like tamoxifen.
Like tamoxifen, which blocks the estrogen receptor directly, or aromatase inhibitors, which are used in postmenopausal women to shut down estrogen production in the body.
And the response rates are high.
Dramatically different. Clinical responses are seen in over 50% of women whose cancers are hormone receptor positive. But if the cancer is receptor negative, the response rate to these therapies is less than 10%.
Huge difference. And you mentioned ER-positive tumors have a different pattern of coming back.
Yes, that's a really important point. ER-positive cancers have a risk of recurrence that persists for longer. While the risk might be lower year to year than some aggressive types, it doesn't drop off as sharply after the first 5 years. They can recur 10, 15, even 20 years later.
Which explains why endocrine therapy often continues for so long.
Exactly. Extended therapy, 5 or even 10 years, is often needed to suppress that long tail of risk.
Okay, hormone receptors, fuel source we can block. Now what about HER2/neu? Human epidermal growth factor receptor 2. That one used to be feared, right?
It absolutely was. HER2 is different. It's an oncogene, a gene that promotes cancer growth. When it's overexpressed, the cancer cell makes way too many copies of the HER2 protein on its surface.
And that signals the cell to grow uncontrollably.
Precisely. It's like the accelerator pedal is stuck down. Before we had treatment specifically for it, HER2 positive status was strongly associated with more aggressive disease, faster recurrence, and decreased overall survival. It was a marker of poor prognosis.
But that story has completely changed.
But flipped. The discovery that HER2 is driving the cancer also meant it could be targeted. Its presence is now a critical predictive marker, telling us the cancer will likely respond to anti-HER2 therapies.
Like Herceptin.
Like trastuzumab, which is Herceptin, and also pertuzumab. These are monoclonal antibodies, designer drugs that specifically latch onto those overexpressed HR2 receptors.
Jamming the signal.
Exactly. They block the growth signals, flag the cancer cells for destruction by the immune system. Adding these targeted drugs to treatment has revolutionized outcomes for HER2 positive patients. What was once one of the worst subtypes is now highly treatable, often with excellent long-term survival. Hashtag tag 2.2 molecular subtypes and associated risks.
Okay, so we have ER, PR, and HR2. What happens when a tumor is negative for all three? That's triple negative breast cancer, TNBC.
Right. TNBC is defined by that lack of expression. ER negative, PR negative, and HR2 negative. And because it lacks these common targets, we can't use endocrine therapy or standard anti-HR2 therapy.
Meaning chemotherapy is the main weapon.
Chemotherapy remains the cornerstone of systemic treatment for TNBC. And biologically, these cancers tend to behave differently. They're often more aggressive, particularly early on.
What are the hallmarks of TNBC behavior?
They have a higher likelihood of recurring within the first 3 to 5 years after diagnosis. The recurrence risk curve is quite steep initially, then tends to flatten out more than, say, ER-positive disease.
So higher early risk. Any other characteristics?
Yes, unfortunately, they also show a greater tendency to metastasize to the brain compared to hormone-positive types. And there's a very strong genetic link we need to talk about.
BRCA.
Specifically, BRCA1. The TNBC phenotype, the triple-negative status, is the way breast cancer most frequently presents in women who carry an inherited mutation in the BRCA1 gene.
Okay, let's dive into BRCA1 and BRCA2. Everyone's heard of them, but what do they actually do?
They're tumor suppressor genes. Think of them as DNA repair mechanics. Their normal job is to fix breaks in DNA, preventing cells from accumulating errors that could lead to cancer.
So you need to lose both copies for cancer to start?
Generally, yes. In hereditary cases, a person inherits one faulty copy, then a mutation in the second copy within a breast cell can trigger cancer development. But the type of cancer that develops often differs between BRCA1 and BRCA2 carriers.
How so? You mentioned BRCA1 and TNBC.
Right. BRCA1-associated cancers are much more likely to be hormone receptor negative, and very often they fit that triple negative profile. They can also have specific features under the microscope, like being basal-like or sometimes presenting as that special type called medullary carcinoma.
Okay, so BRCA1 often leads to TNBC. What about BRCA2?
BRCA2-associated cancers are a bit different. They are more likely to be invasive ductal carcinomas, the most common type overall. And critically, they are more likely to express hormone receptors, ER/PR.
So a BRCA2 mutation carrier might still have an ER-positive cancer that responds well to endocrine therapy.
Exactly. While both increase risk significantly, the kind of breast cancer they typically cause can be quite different, which has major implications for treatment selection beyond just knowing the mutation status. So now we bring it all together. Clinicians take the TNM stage, the anatomical map, and combine it with these key biomarkers, ER, PR, HER2, sometimes others, to really understand the individual patient's situation.
And that combination drives the decisions, stratifying risk, choosing therapies.
Precisely. It's the synergy between staging and biology that defines modern, personalized breast cancer therapy. Hashtag tag 3.1, the need for advanced tools.
We've got the stage, we've got the main receptors. Why isn't that always enough? Why the need for even more advanced tools?
Because even with that information, we were still, historically, over-treating many patients and under-treating others. The sources cite estimates that relying only on those traditional factors, size, nodes, grade, basic receptors, led to maybe up to 70% of early breast cancer patients getting adjuvant chemotherapy.
After surgery.
Right. Adjuvant chemo that was either unnecessary, they would have done just fine without it, perhaps with just endocrine therapy, or ineffective, because their specific tumor biology wasn't actually sensitive to the standard chemo drugs being used.
70% potentially getting unnecessary or ineffective chemo. That's a huge number. That's a massive driver for finding better ways to predict who really benefits.
Absolutely. Chemotherapy isn't benign. It has significant short-term and potential long-term side effects. The push has been to find tools that can more accurately predict benefit from chemo, not just risk of recurrence.
So how do clinicians try to integrate all these factors, TNM receptors, maybe grade into a single risk estimate?
Well, one way is using online tools or nomograms. Adjuvant. Online is a classic example mentioned in the sources.
How does that work?
You input all the patient's specific clinical pathologic details, the precise T stage, N stage, tumor grade, age, ER/PR status, HER2 status.
Yeah.
The algorithm then calculates an individualized estimate of their baseline risk of recurrence and death without any systemic therapy.
It gives a starting risk number.
Right. And then crucially, it models how much that risk is likely to be reduced by adding different systemic treatments, endocrine therapy, chemotherapy, anti-HER2 therapy, or combinations. It helps visualize the potential absolute benefit of adding each treatment layer.
So it moves beyond just high risk or low risk to how much does this specific treatment help this specific patient?
Exactly. It helps quantify the decision-making process.
Okay, but that still relies on the traditional factors. This brings us to the really cutting-edge stuff mentioned, the multi-gene expression assays. These sound like a game changer.
They absolutely have been. These tests analyze the activity levels or expression of a panel of specific genes within the tumor tissue itself. They provide biological information that goes beyond just ERPA2 status.
Looking deeper into the tumor's engine room, let's talk about Oncotype DX. That's a big one.
Oncotype DX is probably the most widely used. It's a 21-gene assay. It uses a technology called RT-PCR on the preserved tumor sample to measure the expression levels of 21 different genes.
Genes related to what?
They're related to things like cell proliferation, invasion, hormone receptor signaling, and other pathways known to be important in breast cancer behavior. Based on this gene expression pattern, it generates a number called a recurrence score.
A score from 0 to 100.
Yes. And this score provides two key pieces of information. It predicts the likelihood of distant recurrence if the patient receives endocrine therapy alone, and it predicts the likelihood of benefit from adding chemotherapy to that endocrine therapy.
Okay, so who is this test typically used for?
Its primary best validated use is in patients with newly diagnosed, node-negative, ER-positive, HER2-negative breast cancer. These are patients where the decision about chemotherapy used to be really difficult based on traditional factors alone.
And a low score means?
A low recurrence score, particularly 0 to 10, based on the landmark KALORix trial, indicates a very low risk of recurrence with endocrine therapy alone, and crucially, minimal to no benefit from adding chemotherapy.
So TAILORx proved you could safely skip chemo in that low score group.
Unequivocally. It was a massive prospective trial that confirmed patients with scores 0-10 had excellent outcomes, around 98% survival free of distant recurrence at 5 years, with just endocrine therapy. It gave level 1 evidence to de-escalate treatment for thousands of women,
Yes.
sparing them chemotoxicity.
That's huge. And the sources mentioned it might also be useful for some node-positive patients.
Yes, subsequent analyses, particularly from TAILORx and other studies, have suggested that for postmenopausal women with limited nodal involvement, 1 to 3 positive nodes, and a low recurrence score, generally under 26 in this context, chemotherapy may also offer little benefit and can potentially be omitted. So its use is expanding cautiously into select node-positive groups.
Okay, Oncotype gives a score predicting chemo benefit. What about MammaPrint? That's another big gene assay. How does it differ?
MammaPrint uses a different technology, microarray, and analyzes a different set of 70 genes. Instead of a score, it gives a binary result. The tumor is classified as having either a low-risk or a high-risk genomic profile for distant metastasis within 10 years.
High risk or low risk? Simpler output. Who is it used for?
It has broader initial approval for patients with stage 1 or stage 2 breast cancer, regardless of node status, up to 3 positive nodes. And it can be used for both ER-positive and ER-negative tumors, as long as they are HER2 negative.
So slightly different gene set, binary output, maybe broader initial applicability. And the key trial for MammaPrint was MIND-ACT.
Yes, the MIND-ACT trial is really interesting. It specifically asked, what if a patient looks high risk based on traditional clinical factors, like large tumor size or high grade, but the MammaPrint 70 gene profile says they are genomically low risk?
So clinical signs say high risk, genes say low risk. Who do you believe?
That was the question. Could chemotherapy be safely avoided in these discordant cases? The trial found that patients who were clinically high risk but genomically low risk, according to MammaPrint, and who were randomized to not receive chemotherapy, had excellent outcomes.
Not good.
The rate of survival without distant metastasis at 5 years was 94.7%, which met the study's predefined threshold for showing that omitting chemo was non-inferior, not significantly worse than giving it.
So in that specific group, the genomic profile seemed to trump the clinical risk factors for the chemo decision.
Exactly. MIND-ACT provided strong evidence supporting the use of the 70-gene signature to de-escalate chemotherapy, even when older clinical indicators might have pushed towards treating. Both Oncotype DX and MammaPrint represent this shift towards using tumor biology to refine treatment decisions, especially around chemotherapy.
Okay, we've covered the detailed staging rules and the crucial biomarkers and gene assays. Let's connect this to actual treatment decisions. How does this complex information play out in real-world scenarios? Hashtag tag 4.1 staging influence on surgery and adjuvant therapy.
Well, one of the most dramatic changes driven by understanding risk better has been in the surgical management of the underarm lymph nodes. This really hits home the practical impact.
You're talking about avoiding the big axillary dissection surgery, ALND.
Precisely. And the trial that changed everything was ACOSOG Z0011. It's a landmark study.
What did Z0011 look at?
It focused on a specific group, patients with relatively small primary tumors, clinical T1 or T2, no palpable nodes beforehand, N0, who were planning breast-conserving surgery, lumpectomy, followed by whole breast radiation.
Okay, early stage planning lumpectomy and radiation.
Right. During their surgery, they had a sentinel lymph node biopsy, the standard test, to check the first few draining nodes. The trial then randomized patients who were found to have cancer in only one or two of those sentinel nodes, PN1A.
So, minimal node involvement found at surgery. What were the randomization arms?
One group got the traditional treatment, a full axillary lymph node dissection, ALND, removing most of the remaining nodes. The other group got nothing further done to the axilla, just the positive sentinel nodes removed.
No more surgery. Despite having known cancer in those nodes, that sounds radical.
It was, but the results were stunning. There was no significant difference in overall survival or disease-free survival between the two groups.
Wow, so removing all those extra nodes didn't actually improve survival for those patients.
Correct. The implication was enormous. For these selected patients, the remaining microscopic disease potentially left in the axilla was effectively treated by the systemic therapy, chemo or endocrine therapy received, and importantly, the whole breast radiation, which covers the lower part of the axilla.
So end staging still happens. We identify the PN1A status, but it doesn't automatically trigger the big morbid ALND surgery anymore for this group.
Exactly. It allows patients to avoid the significant risks of ALND, most notably chronic, debilitating lymphedema, arm swelling, without compromising their cancer outcome. It's a huge win for quality of life, driven by understanding that systemic therapy and radiation can handle minimal residual disease.
But this only applies to that specific Z0001 population, right? Lumpectomy, radiation, only 1 to 2 positive nodes.
Absolutely. Critical caveat. Yes, it doesn't apply to patients having mastectomy without radiation or those with more extensive nodal disease found initially.
Which brings us to the flip side. When is aggressive regional treatment still absolutely needed based on staging?
When the nodal disease burden is high, the staging system identifies these patients. For example, women found to have cancer in 4 or more axillary lymph nodes that's classified as PN2A.
Okay, PN2A, 4 or more nodes.
They are automatically considered high risk for regional recurrence. If they've had a mastectomy, standard guidelines recommend radiation therapy, not just to the chest wall where the breast was, but also to the regional lymph node basins, including the supraclavicular nodes above the collarbone.
So higher end-stage mandates more extensive radiation.
Yes, because the risk of cancer returning in those regional nodes is significant, and radiation is proven to reduce that risk and, in some cases, improve overall survival in these higher risk end-stage categories. Staging directly dictates the intensity of local regional therapy. Hashtag 4.2 biomarkers and the timing of systemic therapy.
Okay, let's shift to how biomarkers influence the timing of drug therapy. We often hear about neoadjuvant therapy treatment before surgery. When is that used, and how do biomarkers guide it?
Neoadjuvant therapy, usually chemotherapy, sometimes with targeted drugs, is given upfront for a few key reasons. One is to shrink large tumors or advanced local disease like stage IAIIB to make surgery easier or even possible.
Downstaging the tumor.
Exactly. Another major reason, especially for aggressive subtypes like HER2 positive or triple negative, is to see how well the tumor responds to the drugs. It's like a real-time test of sensitivity.
And biomarkers are key here.
Absolutely essential. Take HER2 positive breast cancer. We know it's driven by HER2. So giving neoadjuvant chemotherapy combined with dual anti-HER2 blockade, trastuzumab and pertuzumab, leads to very high rates of pathologic complete response, or PCR.
PCR meaning no invasive cancer left at the time of surgery.
Correct. And achieving PCR in HER2 positive and TNBC is strongly linked to excellent long-term outcomes. So the biomarker, HER2 status, directly dictates using targeted therapy upfront to maximize the chance of PCR.
What about for hormone-positive cancers? Is neoadjuvant therapy used there?
It can be, especially if the tumor is large. Sometimes neoadjuvant endocrine therapy is used for strongly ER-positive tumors, particularly in postmenopausal women. The goal is tumor shrinkage over several months.
And you can assess response.
Yes, and there's even a tool called the PPI score, Preoperative Endocrine Prognostic Index. After several months of neoadjuvant endocrine therapy, the PPI score is calculated based on the tumor characteristics at surgery: size, nodes, ER level, proliferation marker, Ki-67.
What does the PPI score tell you?
A very low PPI score suggests the patient had an excellent response to the endocrine therapy alone and may potentially not need adjuvant chemotherapy afterwards. A high score suggests resistance and might push towards adding chemo. So again, biomarkers and response assessment guide subsequent treatment intensity.
Fascinating. Treating first to figure out if you need more treatment later. Okay, finally, what about the duration of therapy, particularly for hormone-positive disease? Biomarkers play a role there too, right?
Definitely. Because ER-positive cancers have that long tail of recurrence risk, the question of how long to continue endocrine therapy is critical. The standard used to be 5 years.
But trials showed longer is sometimes better.
Yes. Major trials like ATLS and ATOM looked at extending tamoxifen from 5 years out to 10 years. They found that continuing tamoxifen significantly reduced the risk of late recurrence and also reduced breast cancer mortality.
So 10 years became a new standard for many.
It became a strong consideration, especially for patients with higher baseline risk factors. The decision involves balancing the benefits against the potential side effects of longer treatment.
And what about aromatase inhibitors in postmenopausal women?
For postmenopausal women, aromatase inhibitors, AIs, are generally preferred as the initial endocrine therapy over tamoxifen, or used sequentially after tamoxifen. Studies show that 5 years of an AI reduces the risk of recurrence by about 30% compared to 5 years of tamoxifen alone.
Better efficacy.
Yes. And there's ongoing research into the optimal duration of AIs too, whether extending beyond 5 years provides further benefit for certain patients. It all comes back to using the initial biomarker profile, ERPR status, to guide not just the type, but also the duration of therapy needed to manage that long-term risk. So when you pull back and look at the whole picture, we've really moved into an era of highly individualized treatment. Staging, the TNM system, gives us that essential structural map where the cancer is, how far it's spread anatomically.
The blueprint, as you called it.
Right, but it's the biomarkers ER, PR, HER2, and now these multi-gene assays that reveal the engine driving the disease. They tell us about its biology, its vulnerabilities.
And combining those two pieces of information, the map and the engine, is what allows for truly personalized medicine, moving away from just treating based on stage alone.
Exactly. You could have two patients with the exact same TNM stage, say stage IIA, but if one is ER positive, HER2 negative with a low oncotype score, and the other is triple negative,
their treatments will look completely different.
Radically different, and potentially equally effective for their specific biology. That's the power of integrating staging and biomarkers.
And that's really the core message for you, the listener. Understanding these concepts helps make sense of why treatment plans can vary so much. Knowledge of staging, receptors, gene assays, it's what empowers both clinicians and patients.
Let's quickly recap the main takeaways then. First, the AJCC TNM system, 8th edition, provides incredibly precise anatomical staging, getting down to millimeters for tumor size and carefully defining even micrometastatic node disease.
Got it. Precision anatomy.
Second, the big three biomarkers, ER, PR, and HER2, remain absolutely dominant in guiding therapy selection. They dictate who gets endocrine therapy and who gets anti-HER2 targeted therapy.
Biology dictates drugs.
Third, those multi-gene assays like Oncotype DX and MammaPrint are revolutionizing risk assessment, particularly for ER-positive cancers. They allow thousands of patients to safely skip chemotherapy based on favorable tumor biology, even if older factors look borderline. Biology often trumps basic anatomy for chemo decisions now.
Using genes to avoid toxicity makes sense.
And fourth, clinical trials like Z0011 have shown us that for carefully selected patients with early-stage disease and minimal nodal spread, less aggressive surgery combined with effective systemic therapy and radiation provides excellent outcomes, improving quality of life significantly. Sometimes less is more, anatomically speaking.
Right. Trusting the drugs and radiation to do the work.
It's a field that's just constantly evolving, especially with genomics.
Yeah.
So maybe a final thought to leave you with.
Okay.
Considering how fast gene sequencing is advancing and how much weight we now put on molecular profiles from tests like Oncotype DX, what might breast cancer staging look like in the future? Could we reach a point where staging relies primarily on a detailed molecular signature rather than just physical size and nodal counts?
Wow. So T, N, and M becoming less about millimeters and node counts and more about genetic risk scores?
Potentially. Could the anatomical stage eventually become secondary to a much more sophisticated biological risk profile, transforming T, N, and M from physical measures into purely predictive data points? It certainly feels like the trajectory we're on, something to think about.